If the patient presents with a constellation of symptoms that can be explained by underlying vascular pathology, then a differential diagnosis of an underlying vasculitis should be considered, particularly if the patient does not have typical vascular risk factors. Vasculitis is classified by the Chapel Hill Consensus Classification into either a large vessel, medium vessel, or small vessel vasculitis category, referring to the typical size of the vessels which the underlying vasculitis tends to affect. There can also be variable vessel vasculitis, which affects vessels of different sizes, and vasculitides associated with underlying autoimmune disease, particularly the connective tissue diseases, which we've discussed in a previous video. As its name implies, vasculitis results in an inflammation of the vessels, which can either lead to ischemic changes or hypoperfusion to the affected tissues, resulting in end organ damage, and hence a constellation of symptoms depending on the vessels which are affected and the organs which are supplied. And in the case of the ANCA-associated vasculitides, inflammatory infiltrates of organs can also be observed due to the underlying inflammatory response of the systemic disease. In terms of large vessel vasculitis, giant cell arthritis is by far the most common subtype of this, which tends to affect the vessels supplying the head, which ascend from the aortic arch. This almost always occurs in middle-aged to elderly patients, so patients aged more than 50, and affects females more than males, and is particularly prevalent in the Caucasian population. Classic manifestations include a temporal headache due to inflammation of the temporal arteries, which may be palpable and tender on clinical examination, visual disturbances secondary to arteritic anterior ischemic optic neuropathy, or AAION, which arise as a result of compromised ophthalmic vascular supply, and jaw claudication, when the blood supply to the muscles of mastication are compromised because of the giant cell arthritis, which leads to ischemic type pains upon activation of the muscles of mastication when chewing food. Giant cell arthritis is strongly associated with an autoimmune arthropathy known as polymyalgia rheumatica, or PMR, which is discussed in a previous video on autoimmune arthritis. The other type of large vessel vasculitis is that of Takayasu arteritis, which tends to affect young adults and Asian females as the main demographic. This also has a predilection for the large vessels arising from the aortic arch, and patients can present with similar symptoms to giant cell arteritis, particularly claudication. If there is severe disease, patients can present with syncope, develop strokes because of the vascular compromise, and in chronic disease states, patients may have a weak pulse, hence the colloquial term pulseless disease. In terms of medium vessel vasculitis, the main subtype that affects adults, although is still very rare, is that of polyarteritis nodosa, which tends to affect males and has disease onset in middle age. As its name implies, the hallmark finding in polyarteritis nodosa is that the medium vessels have an appearance like a string of beads on radiological imaging. It is strongly associated with underlying hepatitis infection, particularly hepatitis C and hepatitis B as well, and is a rare but well-recognized complication of hairy cell leukemia. The medium vessels of the abdomen are typically affected, and hence abdominal pain is a common presenting symptom. There can be renal and neurological manifestations if the respective vasculatures are involved, and patients can have elevated inflammatory markers and systemic symptoms because of the underlying vasculitis. A classic skin manifestation of polyarteritis nodosa is that of livido reticularis, which is a lace-like erythematous rash which usually develops over the limbs, reflecting involvement of the medium-sized vessels of the dermis in subcutaneous tissue. The other subtype of medium vessel vasculitis is that of Kawasaki disease, which is usually a pediatric disease, more commonly affecting males and more prevalent in the Asian population. Typical features include mucocutaneous erythema, and the so-called strawberry tongue appearance reflecting underlying inflammation. Edema and desquamation of the hands and feet is observed, as well as fevers and cervical lymphadenopathy as part of the inflammatory process, and perhaps the most severe manifestation of Kawasaki's disease is that of cardiac aneurysms, which can lead to cardiac complications. Like the other large vessel and medium vessel vasculitides described, there is no specific serology that is detected for any of these diseases, and diagnosis is usually made based on the clinical manifestations and possibly suggestive radiological imaging, along with the presence of elevated inflammatory markers as well as negative serology for the other autoimmune arthritis and connective tissue diseases, which may be a differential diagnosis. Artery biopsy can be useful to help clarify the diagnosis, although this is typically not practical in the case of the medium vessel vasculitides, but is relatively commonly done in giant cell arteritis, where a temporal artery biopsy is commonly obtained. In terms of small vessel vasculitis, there are two main categories, namely immune complex vasculitis and ANCA-associated vasculitis. Because the kidney parenchyma, nerves, and skin are supplied by small vessels, compromise of these vascular beds in the setting of small vessel vasculitis can lead to prominent skin, renal, and neurological manifestations. Rupture of these small vessels can also lead to abnormal bleeding, particularly petechiae or purpura of the skin. In immune complex vasculitis, the immune complexes form because of various mechanisms and deposit in these small vessel vascular beds, typically the kidneys, hence renal involvement, and the skin, hence the purpura. The immune complexes which trigger the inflammatory damage deposit in the skin in a gravity-dependent manner, and hence the typical purpuric rash tends to start in the lower limbs and progress in an ascending fashion. In the case of IgA vasculitis or Henoch-Schönlein purpura, which typically occurs in the pediatric population, the purpuric rash begins and is prominent around the buttock region, which is the gravity-dependent region for infants and babies. The diagnosis of IgA vasculitis is made when there's the typical clinical manifestations as well as biopsy confirmation of the IgA deposits, typically from a skin biopsy of the rash or a renal biopsy if there's severe renal involvement in a nephritic syndrome. The other immune complex vasculitis subtypes include cryoglobulonemic vasculitis, hypocomplementemic urticarial vasculitis, and anti-glomerular basement membrane disease. Cryoglobulonemic vasculitis is characterized by the concurrent presence of cryoglobulinemia, where cryoglobulins are serum immunoglobulins which precipitate in cold temperatures, hence the name cryoglobulin. The cryoglobulin can be a type 1 or monoclonal cryoglobulinemia, which is associated with lymphoproliferative diseases, hence the monoclonal nature, or a mixed type 2 or 3 cryoglobulinemia, where there is also a polyclonal immunoglobulin component, which is associated with hepatitis C infection as well as autoimmune diseases, particularly lupus, Sjögren's syndrome, and rheumatoid arthritis. The quantity and subtype of cryoglobulinemia can be tested for with a cryoglobulin test, and may be suspected if the patient presents with a syndrome consistent with immune complex vasculitis, particularly in the setting of underlying hepatitis C infection, autoimmune disease, or lymphoproliferative disease. The other subtype of immune complex vasculitis is that of hypocomplementemic urticarial vasculitis, where hallmark features include hypocomplementemia, as well as a rash with a urticarial appearance, with the distinguishing feature being that urticarial vasculitis leaves a hyperpigmented ecchymotic-like appearance to the rash, which persists for several days, as opposed to true urticaria, which by definition will fully resolve within 24 hours. And lastly, there's anti-glomerular basement membrane disease, which tends to affect the glomerular basement membrane of the kidneys, leading to renal impairment, and can also affect the alveoli of the lungs, leading to pulmonary hemorrhage. And when there is both renal and respiratory manifestations, this is known as Goodpasture's syndrome. The other type of small vessel vasculitis is that of the ANCA-associated vasculitis, which tends to affect the middle-aged to elderly population. Classically, there's involvement of the sinopulmonary tract, as well as renal involvement and possibly skin manifestations such as purpura and neurological manifestations including mononeuritis multiplex. The three main subtypes are that of granulomatosis with polyangiitis or GPA, microscopic polyangiitis or MPA, and eosinophilic granulomatosis with polyangiitis or EGPA. These three subtypes have overlapping and distinct features. There is presence of granulomatous inflammation in both GPA and EGPA, but this is absent in MPA. There is the presence of eosinophilia, which drives the inflammatory response and infiltrate in EGPA, whereas eosinophilia is absent or not prominent in MPA and GPA, where inflammation and infiltrates is driven by neutrophils. GPA and EGPA can present with pulmonary infiltrates and hemorrhage, whereas MPA tends to present with just hemorrhage from capillaritis. Sinopulmonary tract involvement, particularly collapse of the nasal and sinus passage soft tissue structures, is typically a prominent feature of GPA. Apart from the clinical manifestations, these subtypes can also be distinguished using serology, namely the ANCA test. This detects the presence of anti-neutrophil cytoplasmic antibodies and shows up as either a perinuclear staining pattern, known as a p-ANCA, or a diffusely granular cytoplasmic staining pattern, known as a c-ANCA. The presence of a c-ANCA staining pattern would suggest that there are antibodies targeted to the cytoplasm of the neutrophil, of which the most common protein is that of proteinase 3 or PR3. A PR3 titer can then be done to quantify the amount of autoantibody present. C-ANCA and PR3 is most strongly associated with GPA. In contrast, the presence of a p-ANCA would suggest the presence of autoantibodies to perinuclear targets, which the most common protein is that of myeloperoxidase or MPO. Similarly, an MPO titer can be done to quantify the amount of autoantibodies, and a high MPO titer would suggest the presence of EGPA or MPA, but not GPA. It follows that ANCA can be a useful test in trying to clarify the diagnosis of an ANCA-associated vasculitis, but it's important to note that these ANCA-associated vasculitides present with typical clinical manifestations, and so an ANCA test should not be done if the patient does not have these manifestations. Next, we have the variable vessel vasculitides, which includes Behçet's disease and Cogan syndrome. Behçet's disease is considered rare but has a higher incidence in countries along the Silk Road, so particularly Middle Eastern and Asian countries, and has the hallmark feature of oral and genital ulcers, which can be very severe, as well as conjunctivitis, which reflects small vessel involvement. However, there can also be medium and large vessel involvements leading to neurological and gastrointestinal manifestations. Behçet's disease is unique in that it can affect both arterial and venous vasculature of variable sizes. Cogan syndrome is a rare variable vessel vasculitis with disease onset in young adulthood and the classic manifestations of interstitial choroiditis or other ocular inflammation and vestibulo-auditory dysfunction. Like the large and medium vessel vasculitides, The variable vessel vasculitides do not have specific biomarkers and relies on a largely clinical diagnosis. And lastly, I'd like to mention that there can be vasculitis secondary to underlying autoimmune diseases, particularly lupus, rheumatoid arthritis, and Sjögren's syndrome, which I have discussed in the previous videos. Now that we've discussed the typical features of the various vasculitides, we can go on to talk about the other autoimmune disorders of other etiologies.